I congratulate the investigators on conducting a trial in a population of patients that it's very challenging in order to do trials in this population of patients in a multi-center cooperative group, NCI-funded manner with a detailed battery of neurocognitive tests. These investigators studied patients with 1 to 3 brain metastases that were each smaller than 3 centimeters, and the patients were randomized to receive either stereotactic radiosurgery to each of those lesions, followed by whole brain radiotherapy, or stereotactic radiosurgery alone. And they had 2 main conclusions. First, that a whole brain radiotherapy did not appear to improve survival, and second, that whole brain radiotherapy caused neurocognitive decline. And their recommendation was that whole brain radiotherapy should therefore be deferred in favor of observation after stereotactic radiosurgery. However, I think putting this trial in the context of other trials for patients with brain metastases, I think some alternative conclusions are also reasonable. This study was not powered for survival. The statistical design did not plan to look at survival as the primary endpoint, and so I don't think it is fair to say that this study showed definitively that whole brain radiotherapy does not prolong survival. In fact, several other studies have looked at this question as well, and most have either been underpowered to look at survival or did not have survival as a primary endpoint. When those studies are looked at in more detail, it's clear that there is a subpopulation of patients who survive longer because they received whole brain radiotherapy. And that population of patients are generally those who have controlled systemic disease at the time of study entry. So it's unrealistic to expect that whole brain radiotherapy will prolong survival unless the brain metastases are the site of disease that will cause the death of the patient. And so in the appropriate context, which is when the extracranial disease is controlled, whole brain radiotherapy may indeed prolong survival and should be considered in that population of patients. The second area they looked at was neurocognition, and they found quite clearly that neurocognitive function was worse after 3 months with whole brain radiotherapy than stereotactic radiosurgery alone. That is an important finding, but it's not a new finding. Many other studies have shown the same result. What these investigators also looked at was neurocognition after 12 months, and they found that neurocognition remained worse after whole brain radiotherapy than observation. That is in conflict with other studies that have had a similar design, and that discrepancy at this point remains unexplained. There are several potential explanations for that difference. One potential explanation is that whole brain radiotherapy clearly reduces the risk of recurrent brain metastases, and this study had a very low rate of recurrence of brain metastases in the observation arm relative to the whole brain radiotherapy arm. The lack of recurrent brain metastases to the degree expected among patients who received radiosurgery alone may partially explain why those patients did not also suffer neurocognitive decline after 12 or more months. What these investigators suggest is that taking 2 bad choices, whole brain radiotherapy, which is bad for the brain, or observation, which is followed by more frequent recurrence in the brain, the latter is the better choice. That whole brain radiotherapy is worse for the brain than observation with a higher rate of recurrent brain metastases. Other studies have come to the opposite conclusion. But about this, I think there is no debate. Both whole brain radiotherapy and deferring whole brain radiotherapy with associated recurrent brain metastases are both bad for the brain. And so we need better third options. There are several of those under investigation now. First of all, we know that in many kinds of cancers, such as EGFR mutant lung cancer, these patients have dramatically high response rates to so-called targeted therapies, such as EGFR inhibitors. And those drugs that control disease outside the brain very well also can help to control the disease inside the brain, allowing control of the brain metastases and deferral of the whole brain radiotherapy. Second, there are immunotherapy studies, and immunotherapy is a big topic this year. Immunotherapy, especially in melanoma, also appears to assist in the control of brain metastases, allowing the deferral of whole brain radiotherapy. There are also drugs that are used for dementia, such as memantine, which can also help to improve the neurocognitive function in patients receiving whole brain radiotherapy. There was a trial conducted by the same principal investigator of this trial, Paul Brown, of that drug through what's called the Radiation Therapy Oncology group. And there is a follow-up randomized studies which will be done. The final area of investigation is bending the radiation beam around the area of the brain called the hippocampus. The hippocampus is probably where memory is formed and is a key brain structure which can be injured by whole brain radiotherapy. Using what's called hippocampal avoidance whole brain radiotherapy may be a way to deliver whole brain radiotherapy, help to control the brain metastases, yet avoid some of the detrimental neurocognitive problems associated with whole brain radiotherapy. And there is a randomized trial that will be done of that approach also through the NCI-funded National Clinical Trials Network.